As I was saying, so we have the entire spinal nerves are divided into 31 pairs, 8 cervical, 12 of thoracic, 5 each of lumbar and sacral, and 1 coccyx. And if you look at the spinal cord, spinal vertebrae, we have got the body, which is the central part. Then you have got 2 lateral extension, which are known as the pedicle, and then you have 2 posteromedial extension, which are known as the lamina. The laminal process fused together to form the spinous process. The space of the shape of the vertebral body, along with the different architectural orientation of the different facets, these are different for cervical, thoracic, lumbar, everywhere. If you look at the lumbar vertebrae, this body will be much larger and the space for the canal will be much shorter or smaller. The cervical and the thoracic, they have this foramen. This is the foramen where through the vertebral artery and the spinal, some of the branches of the spinal nerve, they also go through. But mainly this is the foramina for the vertebral artery. So vertebral artery is present in the upper part. So that's why they are present in the cervical vertebrae. So, and thoracic vertebrae body is generally triangular in shape. So, and they have specific articular facets for the ribs. Anteriorly they got the facets for the ribs. That's how you would kind of identify the which part of the vertebra they belong to. Now they have, the vertebra is also surrounded by various ligaments. If you look at the body, anteriorly you have the spinal anterior longitudinal ligament, posteriorly you have the posterior longitudinal ligament. In between the ligaments or the vertebral body, we have the disc. The disc is composed of a centrally located nucleus pulposus and laterally located a jelly-like body. So this entire disc is in between the two vertebral body. Anteriorly, we got the, as I said, the anterior joint or the facet joints, and inferiorly also they got the facet joints for the inferior vertebral body. Posterior to vertebral body, we have got this canal. This is the most important part of a structure of the spinal cord, or rather the spinal, vertebrae, is that this space between the body and the two laminar process. This area is where the spinal cord lies. So if this area is damaged, we get spinal cord injury. Posterior to this, we got various ligaments like interspinous, supraspinous, ligamentum flavum. So superficial to deep, we got the supraspinous, then you got the interspinous, then you got the ligamentum flavum. Once we pierce the ligamentum flavum, we reach the dura mater, and once we reach the dura mater, we almost reach the fluids, the spinal, the CSF, the cerebrospinal fluid, which is surrounding the spinal cord. So there is the round-shaped spinal cord here, and surrounding it is the layer of spinal, CSF. So this is the overall orientation. So as you can see, now I am dissecting the spinal cord as well. The spinal cord is kind of a oval in shape, elliptical or oval in shape. And in this picture, we get that there are two, one anterior and one posterior median sulcus. Along with that, we get one anterior gyrus and two posterior gyri. And there are multiple areas in which the spinal cord on a cross section can be divided. The spinal cord has its anterior spinal artery, which lies anterior to the anterior median groove, and there are two set of posterior spinal arteries which run in the posteromedial and posterolateral grooves. The spinal cord is also that it emits various spinal nerves. As you can see, the spinal nerves form a sympathetic ganglia. So these are the posterior roots of the spinal nerve which form the sympathetic ganglia. So from the various levels, the spinal cord, the nerves, they carry the different sensations of superficial, deep touch, etc. And then they carry to the posterior column. And from there, they will relay into the posterior horn. From there, they will relay into the anterior horn, and then subsequently into the muscle. Some of the portions of, or the some of the exiting nerves, they will again relay, forming a spinal ganglion, T1 to T2 spinal ganglion, and then they will go towards their end organ supply. As we know already that T1 to T12, the thoracic part is mainly sympathetic outflow, and the lumbar part is parasympathetic outflow. And this, if you cross section wise, if you divide the spinal cord again, so you have got three components: anterior, lateral, and posterior. Anteriorly, you got majorly the motor tracts, the anterospinothalamic tract, reticulospinal, vestibulospinal tracts. But laterally, you get the majority of the sensory tracts, which bring the sensation from the peripheral parts towards the brain, namely the lateral spinothalamic, anterior spinothalamic, posterior spinocerebellar. So they will relay from the peripheries towards the various parts of the brain. The spinothalamic tract obviously will relay into the thalamus and ultimately give projection fibers to the cerebrum. The spinocerebellar tract will relay in the various parts of the cerebellum. Posteriorly, you get two tracts, fasciculus cuneatus and fasciculus gracilis. These are made for deep sensation, deep touch, deep pain, vibration sense, etc. So these various parts, again I'll repeat, anterior is mostly motor, lateral is sensory, and that is superficial senses. The mostly the pain, temperature, and touch. These are the lateral cord, and the posterior cord is mainly for the deep touch, vibrations, joint position sense, etc. So spinal cord, the various functions cord level wise, if you look at it, C5 to C6, for example, this is mostly the biceps brachialis and the brachioradialis. So these are mostly associated with flexion of our arm and flexion of the elbows. C7 T8 is mostly the you're talking about the ulnar. So C7 T8 is triceps, so extension of the arm, extension of the forearm, and C8 T1 is mostly the sensory areas of the middle one third of the arm of our hand, along with the flexion of our digits, and it also supplies the lubricants. So that's C8 T1 ulnar. A nerve is a very important nerve, and it is also called as the musician's nerve for that purpose. Then again, in the lower part, if you look at it, L1, L2, L3 are mostly related to the hip joint. Lower part L3, 4, mostly knee extension. So anterior part of the knee is supplied by the L3, 4. And then lower part, lateral part of the feet, where we strike for the elicitation of the Babinski reflex, the plantar reflex. That's S1. Middle part of our sole is mostly L5 and L4. That's how you differentiate the overall, these are all dermatomal projections. Again, this is not the topic for today, but this is a very, very gross overview of our the different spinal cords, their the spinal cord levels and the tracts as per the anterior, posterior, lateral location, and the various dermatomes. The blood supply, anteriorly we get only one anterior spinal artery, which is a branch of the it can be a branch of various levels. It is branch of various. For example, it is a branch of vertebral artery, subclavian artery in the initial part. Then it is a branch of the great radicular artery. So it is a branch at different levels. It arises from different sections. And posteriorly, we get two posterior spinal arteries. One of the important things to remember is that round about T10 to T12 level, there is one artery which is a direct branch of the aorta, which is known as the Adam-Quist artery, and it is a very large branch. And in patients with severe hypotension or anterior spinal artery syndrome, this artery can get ischemic, and you can have an anterior spinal artery cord syndrome. Spinal cord injury is very common. It is occurring in patients who have trauma or they experience some kind of fall. So these are the main two mechanisms of injury, and because they occur in patients or people who are mostly mobile, so they are more common in young patients, more commonly males than females. Mechanism is either, I said, the traumatic, either falls, or it could be road traffic accident, major vehicle accident. Non-traumatic, it could be because of various other reasons like tumor, cyst, infection, etc. Now, interesting part is that the cervical part is the most commonly affected, and that's how you get paraplegic or quadriplegic patients very frequently after spinal cord trauma. Second to cervical is thoracic is the most common part that is affected. But if someone asks you which is the most common site, particular site where the injury happens, the answer is the junction of cervico-thoracic junction and the thoracolumbar junction. Why? Because cervical spine and the lumbar spine are mostly fixed, whereas the thoracic spine is mobile. So anywhere you have a junction of a mobile part and a fixated part, that part is the most part which is most prone to injuries or trauma. That's why the junction of cervicothoracic junction and the thoracolumbar junctions are the most commonly involved in any form of trauma. As you can see, cervical part, they can involve the phrenic nerve and they can cause quadriparesis. Below that level, mostly what happens is paraparesis. This is a representation of a complete spinal cord injury. Supposedly, someone has cut the spinal cord at some level. What you get is pure motor paresis below the level of lesion, and below the level of lesion, you also get complete absence of sensory stimulus. So, total loss of motor and sensory stimulus distal to the area. If you get a partial spinal cord injury, you can have various permutation and combinations of patchy involvement of motor and sensory nerves. Now, important discussion about the critical care wise. Pathophysiologically, whenever a patient comes, we can divide the pathophysiologically the based on the duration spinal cord injury into two parts. One can be an acute phase, which is between say 2 to 4 weeks, and beyond that we call it a chronic phase. So the importance is that during the acute phase, we are dealing with the primary cord injury itself, and we want to prevent the secondary cord injury. If you can if you can recall from the previous class about the brain injury, traumatic brain injury, our motto was to prevent the secondary brain injury like hypoxia, cerebral edema, electrolyte injuries, excitotoxicity, etc. Similarly, here also the same concept applies. We want to prevent the secondary injuries, and notably there are two important phenomena, which is obviously that's why the class is being taken today. That is spinal shock and neurogenic shock. This will be discussed in details. There is some term known as unstable cervical cord injury. SCI stands for spinal cord injury. Sorry. So what is an unstable spinal cord injury? So if you look at this picture, this spinal cord column can be divided in three parts: anterior anterior spinal ligament, longitudinal ligament from there till half of the vertebral body. This is anterior column. Posterior half of the body till the posterior longitudinal ligament is middle column, and from there onwards the posterior part is the posterior column. Importance is that the most vulnerable region is the middle column, followed by the anterior, and the least vulnerable is the posterior. So if you have a fracture of involving the middle column, or you have 2 out of 3, you have disruption of 2 of 3 columns, then you call it an unstable fracture. Very, very important. Why? Because whenever you diagnose that it is an unstable injury, you have to immobilize the spine, call the neurosurgeon for immediate surgical fixation, because later on the neural injuries are going to aggravate. So this is the importance of an unstable spinal cord injury. Now, when we talk about the injury, different types: primary, secondary, spinal, neurogenic. So primary injuries, whatever the mode by which the spinal cord has gotten affected. That could be a flexion injury, like for example, someone has hit the windshield and then their neck is hyperflexed, or it could be a windshield injury which causes extension injury. Someone having a deceleration injury, suddenly someone put the brakes on and then their head goes and collides with the windshield, and the head kind of rotates backwards, suddenly causing a hyperextension injury. Could be a combination of flexion and extension injury. Their head can rotate as well as flex at the same time, causing a flexion rotation injury. That can also go sideways and also can hit any of the wall or the door. So that can cause a lateral injury. So various forms of injuries, various mechanisms can cause various levels of disruption. Secondary injuries is what we want to prevent: the hypotension, the hypoxia, the cerebral cord ischemia, similar to what we have learned in brain injuries, similar mechanisms. So in acute phase, we are dealing with mainly two important particular components, that is a spinal shock and neurogenic shock. Now the easy ways to remember for you guys is to remember that spinal shock is dealt with the spinal nerves and neurogenic shock is related to sympathetic system. Spinal shock is when you cut the spinal cord at a particular level because of injury, the neural supply, the sensory and the motor supply is gone. That is simply the spinal shock. So it is a flaccid paralysis, areflexive paralysis below the level of lesion with associated loss of bladder and bowel control. And so alongside there is a loss of vascular tone, you got vasodilatation and hypotension because of that. So the spinal shock is obviously followed later on by something known as an ADR, autonomic dysreflexia, that we'll have a discussion upon. So spinal shock is simple. If you cut the nerves, there will be no sensory and motor outflow or inflow, and that will cause a spinal shock. Stages can be divided into 4 stages. Initially, in the initial part, there is complete areflexia. So you don't have any reflexes below the level of lesion. So supposedly someone has spinal cord injury at cervical spine C5, C6, below the level, whatever the reflexes are areflexic, the bladder and the bowel is not, well, I mean, there is no sensation at all. They are also areflexic, they are distended. You have to put catheter for that purpose. Bowel is also distended, and the plantars are mute. There is no plantar response. After that, there is some initial reflex that returns in 1 to 3 days, following which you get something known as the early and then late hyperreflexia. Generally, by 28 days, you get early, and then after 28 days, you get hyperreflexia. So, the return of reflexes, but this time they are out of their inhibitory control. So they have a like C5, C6 level. If you have a cutoff, above that there were a lot of inhibitory controls which were controlling the downward centers. Now because that controlling mechanism is gone, they will go haywire and they will have increased reflexes. So beyond this, generally a day 4 to day 7 period, you get increased reflexes, increased. You can have clonus, you can see plantar extension, you can have excessive bladder contraction, hyperactive bladder, etc. You can have. Now, as I said, spinal shock is related to the loss of sensation. Neurogenic shock has to do with the sympathetic loss. What happens is that it is seen purely if you have a lesion above T6. As we know that there is a mnemonic that is sympathetic is thoracolumbar, parasympathetic is craniosacral. So the the sympathetic discharge is thoracolumbar. So from T12 to T1 to T12 and L1 to L5, the spinal ganglion is the one which has the sympathetic relay chain, and that provides a sympathetic outflow to the entire viscera. Parasympathetic, on the other hand, has two sides. One is cranium, the vagus, and the sacral, that is S2 to S1 to S5. Therefore, when you have a lesion or cutoff around T6 and above, so your majority of the sympathetic outflow is gone, and like T6 below, entire chain is gone, and because of that you have decrease in the sympathetic overall outflow. So decrease in the epinephrine, norepinephrine, you get reflex bradycardia because your sympathetic system is down, parasympathetic takes the upper hand, and you get vasodilatation below the level of lesion, causing pooling of blood in the lower limbs, causing hypotension. And this is one of the important things to consider whenever you are managing a spinal cord injury patients. So spinal cord injury patients, immediately post spinal cord, 6 to 7 hours after that, they will come to you, you will intubate, and they will go into bradycardia and arrest. This is because of the neurogenic shock. So bradycardia and refractory hypotension, not responding to fluids, is the initial sign this patient has got a neurogenic shock. Just to again reiterate, neurogenic shock is the fourth type of shock that we know about, or rather the second type of shock among the distributive shock. So we know that among shock can be of obstructive, cardiogenic, hypovolemic, and distributive. Among the distributive, one is septic, and this one is the second one, the neurogenic shock. So this will just behave like a septic shock, except that there will be no signs of fever. So there will be bradycardia, there will be hypotension, and vasopressor refractory hypotension. So for that purpose, what we need to manage in neurogenic shock is start a positive inotropic agent. So you start an ADR infusion, like adrenaline infusion, or you start a dopamine infusion. In our present scenarios, present current practices, there is almost any use of dopamine per se, except for this scenario, where dopamine acts as a positive inotrope, positive chronotrope, and a positive vasopressor. So triple action. So dopamine is preferred in these cases. Now, if you look at the various level wise, and imagine that your C3, C5 is supplying the phrenic nerve, C5, C6 the upper torso and the muscles of the arms and limbs, along with the thoracic cage, and then you got the thoracic level that is supplying the intercostal muscles and the abdominal muscles, and then the lumbar which supplies the obviously the pelvic splanchnic nerves, the genital areas and all. So, if you get a higher up injury above C3, your spinal cord, splenic nerve will be gone, and you have a reduction in the vital capacity, and obviously your cough reflex will also be weak, and these patients land up in intubation, ventilation, tracheostomy, and not even tracheostomy. These patients mostly they don't breathe on their own nicely, and therefore they need lifelong invasive ventilator support, invasive BiPAP support. Sometimes they need diaphragmatic pacing. Below C5, if the diaphragm is spared, their vital capacity is somewhat maintained, their cough is weak but still present, they can avoid intubation in rare scenarios, but again, because of the intercostal muscle paralysis, they require intubation. Now here, I will want to share you one clinical vignette. Patients with high cervical spine injury C3 to C4, they will have phrenic nerve injury. So their diaphragm will be pushed upwards. When you examine them, you will see that they're vigorously having some kind of obstructed breathing pattern. Although their saturation levels initially will be normal, their pulse oximeter will have normal tracing. In these cases, you have to examine them clinically, ascertain the level of lesion. If you see that their upper limbs are entirely weak, upper limb flexor, digit flexor, and the extensor muscles are extremely weak, flexion of the biceps or biceps triceps function is weak, that indicates that it is a high level cervical lesion. Along with them, you do something known as a single breath count test. If your single breath count means you ask the patient to take a deep breath and name as much as numbers that is possible. If they can name more than 25 numbers, means their expiratory muscle power is good. They will not require intubation. But if their single breath count test is less than 10, and or if they have carbon dioxide retention, don't go for the invasive BiPAP and wait for them. Just go for intubation, because these patients have severe phrenic plus minus along with an intercostal muscle weakness. Same thing holds true for these patients also, where you get partial muscle weakness, but you have some amount of intercostal weakness as well. They can also end up in ventilator. Above T8, phrenic nerve is spared, but again intercostal nerves are weak. So these patients, especially if they have comorbidities like a COPD patients require excessive amounts of expiratory muscle workload. If their intercostal muscles are gone, these patients can retain carbon dioxide, can go on in a ventilator. And below T8 to T10 generally is safe because your intercostal majority is paired, and therefore respiratory wise they are safe. Otherwise, but however they have paraparesis.